trying to answer the question why psychotherapy work, does psychotherapy work, has to do with the identification of the so-called change agents. Change agents are agents, factors responsible of change, and since psychotherapy aims at changing something that is considered to be problematic into something that is less problematic, the fact that change is promoted has to do with the efficacy of the treatment. So the issue is what does make a treatment effective? Why does a treatment work? Which are all the things that take place during the clinical work, during the session between client and therapist, more vis-a-vis, so to say, and also between the session. What is responsible or more responsible than other staff for this change? I will try to very briefly summarize some main results of empirical research on this topic and use these results to address and open a discussion regarding the elements responsible of change, which are, as said, called change agents, which are also called therapeutic factors. So therapeutic factor is a factor that is therapeutic, that produces clinically desirable change or change agents. And this discussion will be done reflecting on the issue of the so-called specific versus unspecific factors, or using a more modern conceptualization, unique versus common factors. Just try to avoid yourself to read this. I would like to explain you what you have on the columns and on the lines. On the columns you have the kind of research with regard of the issue if this research is researching one specific modality or different modalities. In the case you do research focusing on one modality, no matter which one it is, you are doing what is called school-specific research, while if you are doing research on at least two different modalities, which get then compared, then you are doing what is called comparative research, where you actually compare different things. This regarding the columns, and regarding the line, you have three different kinds of research having to do more with the part of psychotherapy you focus on. In outcome research, you focus on the outcome of the treatment. The outcome of the treatment is outcome used as synonym first of output, the product of the treatment. And as I was explaining before, to identify to conceptualize an outcome of a treatment, you need to go back to the aim of the treatment. Which is the aim? What do I want to reach? The aim is what do you want to reach, and the outcome is what you concretely reached. And if there is coincidence, or at least a certain coincidence between what you wanted to reach and what you reached, you talk about good outcome, otherwise you talk about bad outcomes. Here we have representatives of different schools, so as I said before, the outcome connected to the aims could be stated at a general level. For example, I like using the term healing or helping. This is a very broadly stated term. Anyway, for each single school it's possible to conceptualize different domains of outcome, and these domains of outcome are related to different domains of aims, and the aims of a treatment are related to the way we see the problem. So, I mean, if I think that the problem is that you have symptoms, the aim would be that I reduce symptom. If I think that the problem is that you have a certain personality structure, my aim will be to restructure your personality. If I think that the problem lay in dysfunctional family relationship, the aim will be to change the dysfunctional family relationships, and so on. If I focus on the outcome of the treatment, that is on the product, I do outcome research, and the question outcome research tries to answer is if a treatment is effective. So this is the question. Is a treatment effective? And the answer is a sort of yes or no. Yes, effective. No, not effective. We have another dimension of the treatment, which is not the outcome, but the process. The outcome is what I want to reach. The outcome is the product of the treatment connected to my aims. The process of a treatment is, this is a definition found in book, which is rather easy for a book definition, but it can be further articulated. The definition of therapeutic process is everything taking place during a treatment. Everything taking place during the treatment. It actually, the idea is that everything taking place during the treatment is something that might or not be responsible for the outcome. But just considering at the moment the process, as I said before, during the treatment can be at least two different things, either within the sessions, which is the most used way of thinking of the process. The process is what goes on within the sessions, that is involving client and therapist and whatever takes place in there, and whatever it really means together. It could also be that the windows gets open suddenly. This is part of the process. The meaning of this for the process is another issue. If it's a positive, negative, irrelevant, but in terms of definition, everything taking place there is part of the process. Also that I hear a police car driving fast, okay? And then there is not the within session process, but the between session process. Only in the last years, researchers have began to pay attention to the between session process. Why didn't they do it before? I don't know. I think it was simply easier and more intuitive to think of within session behaviors and events. The idea of the process as taking place also between the sessions and not only within is something that I think that would make sense for every thoughtful clinician. I mean, we cannot imagine that a client arrives, is able to change only for this, excluding the high frequent treatment forms like psychoanalysis, but also in that case anyway, 50 minutes a week. Imagine of how many minutes is made alive. A treatment of 1 year, consider 1 year how many minutes. Could you imagine that treatment works only because of what is going on during the session? I like the metaphor or the analogy with the gym, training in a gym, doing muscle workout. The principle for the aim is that the muscle grows, and the principle there is rather simple. You shouldn't go every day, and the aim of the training is to give some inputs to the muscle, and actually you will reach the outcome if the quality of the outcome really depends on what you do between the sessions. If you sleep, if you sleep enough, if you have a good, if you eat as you should eat. So this, and the muscle, if it has to grow up, it grows up during, between and not. So this is an analogy I like to imagine how the process of psychotherapy can bring up specific changes. So the research focusing on the process is research focusing on everything takes place within and eventually between the sessions. The examples of outcome research is to see if CBT is good at reaching its aims, like symptom reductions or whatever you might imagine. The same for psychoanalysis, the same for humanistic therapy, the same for systemic therapy. The question there is rather simple. Is it effective? Yes, no. And then you have only to choose the domain with regard of which you define effectiveness or not, which is connected to the aim, okay? For process is a bit more complex, since actually you potentially have to do with everything taking place during the session. So it could be potentially everything. But then as a researcher, you do as you do also in life, that among all the possibilities of possible things that you could observe and ask you questions about, you select some things based on things that are for you interesting, and things are usually for you interesting, mainly, though not exclusively, based on the theory of reference that you have, which usually is the theory of the model you were trained with, plus the theory of whatever you might know, okay, which drives your attention on. Well, an example of research done on the process, which is called process research. Let's imagine for one specific modality, psychoanalysis. It might be if transference interpretation produces insights. These are two elements of the process. These are two things taking place during, or if, I don't know, if insight is connected to a reduction of resistance, and which intervention produce an increase of resistance and which intervention produce a decrease of resistance. These are all questions dealing with process. There is no mention of the final outcome I want to reach, which could be less narcissism in this person. It's process. Well, and then we have a third domain, as you see, where you connect process and outcome. And this is process outcome research. Outcome research alone has a limitation. You find out if a treatment works, but you're not able to say why. And this kind of information might be interesting for some people, but not for some other people. Usually, the people for whom this kind of information is rather irrelevant are clinicians. They tell researchers, what should I do with, you now did a couple of very complicated studies and you're telling me that it works, but I already knew that it works, and I also knew that sometimes it could not work. But it's relevant, for example, for policymakers. Policymaker, health insurances, they want that fact. They don't care a lot. Why? For them it is enough that it works. Then process research has the advantage that it lets you find out connections between phenomena taking place within the session, but it doesn't tell you if all this stuff produces at the end a good outcome. For example, that interpretation might produce insight, fine. We all expect insight as clinicians, and we all have a theory that the more insight, just to make it easy, the more insight, the more probable a change in personality, which is the final outcome. But in a study focusing only on intervention, interpretation, and insight, you don't know if an interpretation which effectively produces more insight has the effect at the end of changing the personality of a client. In order to connect the process and the outcome, you need to do process-outcome research, where you try to connect this. And process-outcome research is that kind of research which allow to identify why therapy works. Not only if it works, not only what happens in it, but connecting what happens in it. And if it works, you find out why it works, okay? So just to give you a couple now coming to the content of the cells. In school-specific outcome research, you have the question, does the treatment A or B or C, one treatment, psychoanalysis, CBT, humanistic therapy, show efficacy compared to what? Compared to a no-treatment condition, known somehow also as placebo condition, control condition. In comparative outcome research, the question is if the treatment A shows more efficacy than the treatment B. Is psychoanalysis more effective than CBT in the anxiety disorder, personality disorder, whatever. In process outcome, as said, you ask what happens in the treatment A or B or C or D. And in comparative process research, what happens in the treatment A compared to B. So for example, if you consider maybe you to divide intervention in supportive interventions and I call them usually restructuring interventions or change-oriented intervention, you might investigate and you observe these two kinds of interventions in different schools. You might want to find out if there are schools which are rather supportive rather than change-oriented, or vice versa. This would be an example of comparative process research. And then you have process outcome research, where the question is which relationship there is between the process and the outcome in psychoanalysis, in CBT, in systemic therapy, and so on. And in comparative process outcome, which relationship there is between process and outcome in the treatment A compared to B. Okay, so I find out that some interventions produce higher degrees of self-reflection, but I want to see if this relationship produces more good results in one treatment than in one other. So just to tell you very briefly what has been found out. I'm trying to summarize here sort of 8 years of research. So regarding this cell, it has been shown that psychotherapy works. Psychotherapy is more effective than placebo. Of course, you say, but in the 30s, as Eysenck made his provocative statement that it was not like this, this is actually the statement which promoted the explosion of outcome research with the aim of showing that clients do not get better because of spontaneous remission. This was his provocative explanation. Clients get better because they do psychotherapy. And if you do psychotherapy, you will have more probability of getting better than if you do not. In comparative outcome research, most of the studies showed over 50 years, 60 years of research that different schools show the same efficacy. No school is better than any other, even if you consider specific domains of the problems of the clients. So to say, in between 80 and 90% of the cases, different schools show the same efficacy. And if you find a difference, the difference goes usually in the direction that process-oriented treatments or long-term treatments like psychoanalysis, psychodynamic therapy, some form of humanistic therapy, some form of systemic family therapy could be better for working on personality disorders, and so on, while CBT and similar treatment forms are more effective for treating anxiety and disorders. They found also those differences, but those differences are found 2 times out of 10. In 8 times out of 10, there is no difference. Which is the truth? Both. Most of the time the same, but sometimes also difference. With the no different situation seemingly being bigger. Process research. They have found out a lot of things. I try to summarize it here by saying that there is a specific relationship among different process variables. For example, there are specific kind of interventions in specific schools which are more connected to an increase, for example, of emotional expressivity, emotional expression, while some other interventions are more beneficial to increase self-reflection. And so a lot of things, very hard to synthesize everything here, but this is usually the direction. And for comparative process, actually, this has been done especially at the level of theoretical research. They found out that there are some processes which are school-specific. For example, interventions are usually one of the things through which you may distinguish between schools. I'm not reductionistically saying that different schools are characterized only by different techniques, but for sure, different techniques are one of the elements which, more than other, show us the difference between different schools. Process outcome research, school-specific. Well, it means that they tried to, within each school, they have been trying to find out which are the aspects of the process which predicts the outcome. And they tried with a lot of things within each school, school-specific. And they always found that the therapeutic alliance, if you study only psychoanalysis, if you study only CBT, if you study only humanistic therapy, and so on, every time the quality of the therapeutic relationship is what predicts mostly the results. For the rest, sometimes yes, sometimes no. In this school, maybe like this. In this other school, more like that. So the summary is, over the schools, and this is what has been found here, over the schools, alliance is the aspect of the process which more strongly and more homogeneously predicts outcome. Other stuff, not so really. So if you consider, what about techniques? Techniques, does the application of specific interventions predict outcome? Yes, but much less than the relationship. And not so frequently and not so homogeneously. Concerning comparative process outcome research, now the point is, imagine we found out that up to now alliance seemed to be something which plays a role in different schools, in predicting outcome, while the rest still unclear. Now the question is, okay, what could we say about alliance if we do comparative process outcome research? I'm telling you that alliance is important in every school. Is this enough to say, well, then I wouldn't expect any difference of the role of alliance in the different school? One of my ideas is, for example, that, okay, alliance is important in all the schools, but what could be interesting is to find out differences in how alliance is constructed over time, so that maybe you might find out that in some therapy models, alliance, the construction of alliance is more a rather linear process, more and more. In some other cases, it has such a, it begins slow, then gets better, then crisis, and so on. Okay, this is the in research, in modern research, this is called shape of change approach. So the idea is, given that something is important for different models, could it be any way possible that the difference is not in how much it is important. It is important in every school a lot, but the difference could be in the shape of change, which tells us a lot. If I should do an hypothesis here, a very simplified hypothesis, I would imagine that in short term, supportive-oriented therapies, the construction of a good alliance is a rather linear process, while in some other treatments, maybe more long-term oriented, the alliance is a process which develops more, is something that develops more slowly over time, and then which is subjected to crisis, the so-called alliance ruptures, and then it goes on, and then if I would imagine something like this. Okay, so this is the idea, and there is almost anything on that. There is really a little bit. So they have done studies showing that alliance can develop, for example, in this way, in this way, in this way, but they still didn't try to see if different schools have different shapes. This is something which is still open. And this is an hypothesis that I have, and this is something that I'm trying to do. We are still collecting data. When you do this kind of research, you may imagine here you have the time, you have the sessions. And depending on how long the therapists that you are investigating take, it might take 2, 3, 4 years to collect data. So I'm working in a project where we began to collect data 4 years ago, and we are still collecting data. So this is a little bit so these results bring to the issue, trying to connect this to the main question, why does psychotherapy work, as we said. Why do you think that psychotherapy works? Or as we said, which do you think are the change agents in psychotherapy? And as I anticipated, based on those results, there are two communities believing two different things. There are the supporters of the so-called specific factors hypothesis and the supporters of the so-called unspecific factors hypothesis. Now, just to give you an example, a visual example of what is meant by this, specific and unspecific. Actually, imagine one therapy school, the second, the third, and so on, okay? Now, this idea comes actually from the biomedical research. In biomedical research, these are the tablets, and then in each tablet you have the active ingredient, right? Which is different. The logic of biomedical research is that these three different medicines produce different effects because of the three different active ingredients. These are the specific elements, and the rest is the unspecific element. This is unique to each medicine, and this is common. Now, based on this idea, and as I said, usually, just to make it easy, although it is more complex, the specific factors, the first specific factors researchers and clinicians think of are the techniques, because are usually very school specific, although not always necessarily, okay? But interpretation of unconscious conflict is clearly psychodynamic, okay, and so on. The correction of irrational beliefs is clearly cognitive behavioral, and so on. And just to make it easy, this polarization between specific and unspecific, what could this white part be in the different schools? So these are the specific interventions for 3 schools, and this, the rest is, what do you think? Relationships plus hope and things like this. You know, things that you...
Specific factors outside of psychotherapy.
Things that you know are present in different schools. Now, if you believe that these three medicines or these three therapeutic models work because of these three different active ingredients, you will expect different effects. If you find that the effects are the same, it means that probably what produce these same effects over the treatments is not due to the differences, but due to the commonalities. Now, empirical research, comparative outcome research, told us that in most of the cases, the red one is the situation. Same efficacy. That's why the idea, maybe they work not because of this, and in 20% of the cases blue. So it's because of this specific part. So there is a great debate on that, okay? Now, this was to tell you how the debate was called at the beginning, and now just to tell you how it is called. I won't go into the details of why unique versus common is better than specific versus unspecific. But consider that, for example, one of the reasons is that unspecific has to do not only with something that is common. Unspecific could be something that has not been investigated, that you don't care of, and that's why they prefer now not to use unspecific but to use common. Well, unspecific is something. If you follow the logic of biomedical research, how do you call it? Füllstoff. This material around this. The material of the tablet is actually something unspecific. You don't care. You put it just so that you. Yeah, something like this, so that you can swallow the tablet.
The medicine is called the vehicle.
Yes, exactly. So this is unspecific, but as soon as you begin to pay attention to that, maybe the word unspecific is a bit misleading or de-evaluating, and that's why common, and just also for the sake of symmetry, unique versus common instead of specific versus unspecific. This is only a terminological commentary, but which reflects some conceptual ideas behind it. Now then we are finished. I'm also going to a bit too long, 8 minutes longer. Well, just an example. I already told you I won't go into the details, but just to unique factors up to now identified in the literature. In those 20% of the cases where there are differences, the differences are very often due to the different techniques. Behavioral interventions correcting false beliefs in CBT, interpretative intervention, especially in psychodynamic therapy, psychotherapy, chair work, and so on in experiential therapy, and reframing and so on in systemic family therapy. This is a very, as I like to say, dummy list for dummies. It's very easy, you know it, but just wanted to give you a visual input about that. What about the common factors? We always talk about relationship, quality of the relationship, yes, but there are other stuff. This is a version offered by Carazu. He was doing theoretical work and he produced these three, he called them common therapeutic factors. He tells you that being able to have emotional experiences, being able to reprocess things at the cognitive level, and be able to regulate your behavior, these three are three common therapeutic factors. Things that should happen in order to produce change, and these three things happened to a different extent in every school. At this level, in the literature, they usually talk about change processes or, change processes. This is the level. This is not the level of the specific techniques. This is the level of the change process that a specific technique might put in movement. So it would be interesting, and there is already at least one empirical study about that, to connect such general change process or principles of change with specific techniques. Which techniques in different schools are more related to this, produce this, and which techniques produce this, and which techniques produce this. This is another conceptualization from Lambert and Ogles, support learning action implementation. In this case, 1, 2, 3, it is also a sequence for the authors. They tell you should first support the client, then you should allow the client to learn something, and you should allow him at the end to implement this new learning in actions in terms of making this concrete. Grave, therapeutic relationship, problem actualization. It means that a problem must get actualized in the session. It must be made, it must be enlived again. Otherwise, you cannot work on it. I think of, what's the name of Pongo? No, you know Das? Das was that plastiline. 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 If you have a shape made of, you have something made out of plastiline. If you want to shape it, you have to make it warm again. And this getting warm again, I associate this with actualizing the problem. You know, because when you make it warm, then it gets dangerous for the form, because there is the possibility that it changes. So a problem must get actualized. You must activate resources, you must deal with motivation, and you must cope with problems. So these are, again, principles of change. Some authors call them strategies. So a strategy is, what do I want to reach in the middle term by my interventions? I might want this, 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 or this, okay? So this is showing you that that beyond the quality of the relationship, therapeutic alliance that is always named, if you move at the level of clinical strategies or change processes associated with specific intervention, you may begin to, also by theoretically and clinically speculating, to identify things that are desirable in therapy, no matter which school you come from. And this is a list, again, made by them, who try to summarize many other things found in the literature. They divide them in client characteristics. For example, the severity of disorder is something which predicts the outcome. The more severe the disorder, the less outcome, no matter which school. Motivation. The more motivation, the better the outcome, no matter which school. Occupational problems, no matter which school. If the clients have occupational and money problems, they have a worse outcome, no matter which school. Therapist characteristics, which are usually used in connection to the alliance, but actually are therapist characteristics, are the very well-known Rogerian characteristic: empathy, warmth, acceptance, congruence. Change processes, which are this. Treatment setting, the fact that you use techniques, no matter which, but the fact that you use them, Frank called them rituals. The fact that there is a ritualization, that there is the fact that the client has the feeling that the therapist is doing something with him is enough. Plays a role. The fact, always from Frank, that the therapist provides a rationale, an explanation of why can this be helpful. This can be done at an explicit level or at an implicit level, but it plays a role. And then the therapeutic relationship intended in terms of good therapeutic relationship, which is also called alliance. So the therapeutic alliance is a good therapeutic relationship, which has been called working alliance, and has to do mainly with interpersonal coordination at any level. Coordination means that we do things together in the same way. in operational terms, mostly in research, alliance is defined as sharing aims. We want to go both in that direction. Methods, we want to use the same things. And bond, we like each other. I like you, you are sympathetic. You are sympathetic to me. Not always, but in general, I like you, okay? But at the more general level, I really believe that the alliance is the product of a process of interpersonal coordination. We get coordinated. I arrive and I work like this, and you work like this. And coordinating means that we get attuned. And we begin to, what I do influences what you do, and so we get one. At the beginning, we are two independent elements, and with coordination and attunement, you have a closed gestalt. You have a gestalt that gets closed. This is the main idea. So these are the examples of common factors. Some of them have been empirically supported more, some other less. Among all of them, the one which has got the most empirical support is the alliance. And for the rest is still not clear in which direction to go. And I think I'm finished. Yes, the conclusion. This might be self-evident, but I know that it's worth to tell it. The issue is not, as it has been until a couple of years ago, does therapy work because of the specific or unique, or because of the unspecific or common? It's not an either-or question. It's a question of how do they work together? I always, with regard of this, I make this example. If you take the specific and common apart, you will have this, and this, okay? Three different things. And then you will have here plus, and then you will have, some people think that you will have just these three, but actually you don't have this. It's like a muffin. If you take the chocolate piece away from a muffin, you have a muffin with a small hole. What does this picture show you? That what we think is the same at a theoretical level. Quality of the relationship, I like you, respect, warmth, empathy. But actually that the way that therapeutic alliance is constructed around school-specific elements. It is different to construct an alliance with a therapist lying behind you, sitting behind you, and you lie, could be a lapsus, but I'm not a native English speaker, and you lay down, or a relationship with a therapist that once in a while asks you to sit on another chair and to do this. I mean, it's different. So what we think being the same, the alliance, the value of the relationship is built around specific elements. I always make the example of collant. You call them collant? These socks, women? Also up to here, doesn't matter. Stay-ups. This kind of women's socks. You imagine you take three models, three pairs which are the same, exactly common factor, same size, same color, and whatever. And then you give them to three different women with a different morphology. When they put them on, they get adapted. So you have the result is something which is common, but this commonality is organized in a specific way in each woman. And this is the idea of the interaction of common and specific. And this is a bit how I imagine it.